Welcome once again into the Radiopedia Reading Room, a podcast unconcerned with books or poetry, tea leaves or palmistry. This is a radiology podcast. My name is Andrew Dixon, and joining me, he used to do something, but now he's just a vestigial remnant. It's my co-host Frank Gaylard.
Even by your standards, that's a bit harsh. But in all fairness, I am feeling a little bit like a vestigial remnant lately. Colleagues at work who are once upon a time, they were my fellows and I taught, are now asking me for advice on scans. And I'm starting to get the feeling that they're doing it just to be polite, to keep me involved.
Yes, well, I have registrars that I trained who are now the consultants approving my leave requests. And they're telling me that I have to come into work on this date, and they're bossing me around. But Alex, if you're listening, I love you very much. You do a great job with the roster, and I really need that week off to go to Hamilton Island.
Oh, using the power of the pod.
I'm not sure. Could backfire, I reckon.
It could. But that is the cycle of life. We were once learning, then we grow up, and now we're going to be the ones that people try and keep us in the loop just out of a sense of obligation as we shuffle around, losing our glasses and not knowing where we are.
With like the two old gentlemen sitting up watching the Muppets show.
Yes, we can be like Waldorf and Stadler. I think that's their name.
Now, actually, that reminds me, did I send you the other day that automated description I found of us as podcast hosts that came up on one of the big podcasting platforms?
Oh, yeah, I think you did.
Yeah, so there's these descriptions that we didn't enter ourselves. We had nothing to do with, I'm pretty sure. I can only assume AI has written them. They've accessed the episode transcripts. And here's what it says for each of us, Gaylard. So Andrew Dixon, it says, co-host and educator known for humorous exchanges and expert discussions in the field of radiology. And for you, Gaylard, it says, co-host and experienced radiologist who engages in light-hearted banter while discussing substantial medical topics.
Substantial indeed.
I think by experienced radiologist, it means old man.
Ancient. Speaking of ancient, I was at the gym just this morning for my weekly humiliation session with my trainer, Sean. Sean, if you're listening, and I'm almost 100% certain that you're not. He's amazing. He's a 25-year-old something or other, super fit with tattoos everywhere, including his neck and face and temples. And he looks like the kind of guy that if you met in a dark alley, like he would take your kidney with a spoon. But actually, he's a really sweet guy. Anyway, he told me today, all wide-eyed and excited, about a new discovery about the ancient pyramids of Giza and how there are multiple 700-meter deep shafts that connect to this 80-meter cubic-shaped room underneath, and how it's believed that these were used to create energy or something, quantum. Did you hear about this? Because it's all over the place, apparently.
No. But my kids did used to watch Scooby-Doo too. Sounds like Sean still does.
Well, it sounded like complete rubbish, like the pyramids were constructed by aliens for landing craft, those kind of conspiracy theories. But I looked into it, and it's actually semi-interesting. So it's been claimed very recently, these claims have been made by two researchers whose names are Corrado Malanga from Italy's University of Pisa and Filippo Biondi from the University of Strathclyde in Scotland. Although Filippo Biondi does not sound like a typical Scottish name, so I'm guessing they're both Italians. Anyway, they've done some research on the pyramids in the past with ground-penetrating radar, and they published an article, which we'll link to in the show notes, and in 2022 this was, where they used radar to reconstruct the internal architecture of one of the pyramids. So, and I mean, I'm no ground radar expert, but the article it looks very good. It's very long. It has lots of equations and charts and things. And so now they've gone back and used the same technique to look under the pyramid, and they claim to have found these massive, massive structures. It seems like this is a fairly controversial claim, and they have made these claims without actually publishing anything yet, which is always a little bit of an alarm bell. But
Yeah.
who knows? Maybe there is, an ancient Egyptian alien civilization and with fusion reactors.
A podcast I listen to, which is called The Skeptic's Guide to the Universe, they
Ah,
often
yes.
describe this kind of stuff as blob-squatch in reference, obviously to Sasquatch and Bigfoot. This phenomenon whereby people look at, usually poorly resolved blobs and artifacts in order to tell a story that fits whatever narrative they want to tell.
Yeah.
And I think there was that recent Amelia Earhart plane crash site is a really good
Oh,
example of this. They had some, deep vision sonar, same as what you're talking about here, deep
yeah.
penetrating radar. And they had these images and it looked like a plane. They're saying, oh, it must be a plane. It's just next to some South Pacific island or whatever. Anyway, turns out eventually someone goes there and looks at it. It's just rocks.
Yep.
But most people only ever see the original news story where it
Yeah,
says,
exactly.
Amelia Earhart plane found, blah, blah, blah. They won't actually see the scientific answer.
Oh,
It's terrible.
blob-squatch. I'm going to start calling ultrasound that these days because that's how I feel whenever I have to look at an ultrasound. It's like, well, I think that might be a kidney. It looks kind of kidney shaped.
Look, I would say it kind of is on static images, but ultrasound's a dynamic test,
It
Frank,
is.
and you can see the kidneys very nicely if you look in real time. Now, up top, I said obviously vestigial remnant, and that's mean. But what I do, Gaylord, I have to be mean in order for the occasional time where I'm not mean in the intro to really stand out and to
To
make you
stand
feel good
out.
about
Right.
yourself.
I
Yeah, yeah,
see.
yeah. So
I see.
you got to treat you mean to keep you keen. Anyway, so vestigial remnant, obviously a reference to the appendix, because today's main segment, Gaylord, we're going to listen to a discussion recorded at the Radiopedia 2024 virtual conference about diseases of the appendix, and it is hosted by the smoothest voice in radiology, Dr. Vikas Shah. And his guest is fellow UK based abdominal radiologist Carla Goncalves. So, Carla works at Guy's and St Thomas NHS Trust in London. But before she became a doctor, Gaylard, she did something else, which is very interesting. And it
Hmm.
comes up during the discussion. So, I
Oh,
won't
okay.
spoil it, but it is one of the reasons why I selected this for today's episode.
I am going to listen to that intently. You've piqued my interest, Dixon.
Excellent, excellent. Good man. Now, there are a couple of little things that I need to mention before we listen in, Frank. Do you
Mhm.
know about ham and lamb?
Is this your veiled attempt at getting me to do a meat update?
No, surprisingly, I've looked through the emails and we haven't had anyone write in asking for more of that meat
Oh, I wish
recurring
someone
segment.
would. That would be awesome. Please write in and ask for more meat related updates.
No. So, with regards to appendiceal neoplasms, not meat, there was this 2016 consensus statement published by what are they? The Peritoneal Surface Oncology Group International,
I'm sorry, but that's the kind of group I desperately want to be on.
which is what? P. Soggy. And that divides tumors into those that are pre-malignant, so mainly adenomas, those of uncertain malignant potential, and the malignant ones, which is essentially the mucinous adenocarcinomas of the
Mhm.
appendix. So moving back to those uncertain malignant potential ones, these are further divided into LAMs, LAMNs, and HAMs, HAMNs, which is low-grade appendiceal mucinous neoplasms, and high grade appendiceal mucinous neoplasms. So I only mention this because you'll hear Vikas and Carla say ham and lamb during this discussion, and that's what they're referring to.
Well, that is, I think, going to be helpful because I would have been even more lost than I'm going to be. Descending down to the level of the appendix to me feels like descriptions of traveling up the Congo into the deepest, darkest center of Africa from the 1800s during the ivory trade. So let's go. I've got my pith helmet on, and we can do this.
Before we go, one more thing. Do you
Mm.
know what the Fagan nomogram is?
I know what a nomogram is, I think. It's a chart with lots of scales and things, and you draw lines
Yes.
to work out values. But Fagan, isn't that an Oliver Twist character?
Yes, yes. Fagan with an I is from Oliver Twist, but this is Fagan with an A. So
Ah,
essentially, the Fagan nomogram is this quick method for calculating post-test probability, and you're going to hear it come up a few times as assumed knowledge in this panel discussion. I might come back and describe it in a bit more detail in the outro. I'm sure everyone will be hanging out for that one.
Excellent. Very exciting. Before we go, any April Fool's updates? Are we allowed to talk about that yet?
Well, we're recording this just before April 1, but it will come out after April 1. Perhaps though we should just wait for next episode.
Okay.
I do have an April Fool idea email that one of our listeners sent in, so I'll read that in the outro.
Oh, good, good, good.
But
Okay.
I reckon it's time to give the listeners what they want, Gaylard. What they're here for. It's time we all heard from the smoothest voice in radiology. So I'll hand over now to Vikas Shah, and then Frank and I will be back for another chat in the outro.
Okay, so I'm now joined by Carla Goncalves, so we can have a chat about our lectures. Hi, Carla, great to see you again.
Hi, Vikas. Lovely seeing you again.
So we're both abdominal radiologists in the UK, but we only ever seem to meet when it comes to talking on a Radiopedia meeting.
Yeah.
Most people listening to this will actually not know that Carla actually did a degree in astrophysics before changing tracks to medicine and then radiology, which is actually really fascinating, Carla. So tell us, why did you change?
That's actually a very difficult question. But I think when I was in school, I always liked physics and maths. I found it kind of, quite easier to follow. And I also had the telescope when I was a kid. And if you haven't done so, you definitely need to kind of look at planets through a telescope. You're not going to see kind of massive pictures like you see in books, but you'll definitely have a perspective that it's a 3D thing. You can actually see the rings of Saturn and kind of the stripes in Jupiter. Just go and watch it. It's really amazing. So at that moment, I can care less about medicine. And I always thought that medicine is about memorizing. You're probably better than me, but my memory is a sieve. I just can't, memorize things. So, at the time didn't make sense. And it was when I was doing research in radiation physics, I came into contact with medicine. And I think all of us will appreciate actually memorizing is a very small part. And we need to use loads of reasoning and logic, in our reports and practice. And I think sometimes we don't learn that at medical school and we don't discuss this much. I think in terms of work, astronomers sit in front of computers and, an hour in the dark, and the same for radiology. So I think for me it was perfect. I just moved the what's on the screen. That's all.
Okay, so your lecture about disease of the appendix was really fascinating and you covered so much interesting material. It's easy to think of appendicitis as like an easy diagnosis, right? It's one of those that
Yeah.
when you see the request come up on your CT list, career appendicitis, you think, okay, that's going to be quite straightforward. I'll get that one done. I really love the way you delved into the nuances of things like pretest probability and the choice of the imaging test and some of the less common appendix diseases as well. So I want to talk to you about all of those. But first, I have a really, really important burning question that will actually divide our audience into two groups. Okay, so I want to know what your
Okay.
response is. So, which is correct, appendectomy or appendicectomy?
Oh, okay. So I believe appendectomy is the American English and appendicectomy the British English. English is not my first language, and I think I'm arguably biased, but I think I might go for appendicectomy as correct. Although in reality, I think both are fine. It's
Yeah.
all right. Yeah.
Being a British English speaker and radiologist, I think appendicectomy is 100% the correct and only option.
Me
But,
too.
but actually, to be fair to our audience who are from across the world, I think both are okay.
Both are fine.
Absolutely. Just say whichever you prefer.
Uh,
So, right, let's get into appendicitis. So, every department will have a different policy of how they approach the imaging of query appendicitis. So, what's your department's first line test? And what I really want to know is, does that vary by which time of the day it is or which day of the week it is? Does it depend on the patient's gender or their age? Do those factors play any role in the decision about which imaging test they would have?
Yes, definitely. So our surgeons will follow the Royal College of Surgeons, acute abdominal pain guidelines, which are very ultrasound heavy. So that's is going to be kind of the most or the first line that we see. I'll just note that one thing about that pathway is that the first branch is high likelihood of appendicitis or atypical appendicitis. So their first point of decision making is the pretest probability, which I love. And then depending on size of patient, gender, ultrasound will be definitely the most common that we use as a first line. older patients, obese patients, then CT. And at least kind of at Guy's and St. Thomas, we have an ultrasound department for emergency cases from 9 a.m. to 5 p.m. And that picks up most of the cases. Out of hours is definitely much more difficult. We only have one registrar overnight, so they can't do everything. So occasionally we might need to do CT. Although our surgeons many times are happy to actually send the patient home or wait for 9 a.m. to have an ultrasound. So on the 9 a.m. slots, we do see this. So it does vary in terms of kind of MRI, kind of for pregnancy. Same thing. I think out of hours is quite difficult to get. Although, sometimes we will try and kind of organize it, but it's definitely not always possible.
Yeah. So if it's a young female patient, say, presenting with
Mhm.
right iliac fossa pain, Curie appendicitis, Curie ovarian cyst rupture, something like that,
Yeah,
versus a young man of the same age,
absolutely.
would it be the same kind of approach? Would it be ultrasound first and then move on?
That's an excellent question. So our surgeons will actually rely a lot on the pretest probability. So if they have a high likelihood is an appendicitis in a young male, they'll actually just operate because there are not many differentials. With females, we do have kind of a much broader differential, basically gynae. So in those patients, we'll do ultrasound all the time. I don't think they'll operate without imaging.
Yeah, so that's interesting because in our institution, there's a policy of there must be an imaging diagnosis first before any surgery for appendicitis. The nominal first line test is ultrasound and then CT. But the reality is, ultrasound is often not easily available at certain times, certain pinch points across the week. So,
Mhm.
evenings, some weekends, because there's limited radiology staffing. They're very busy with the acute CT, and I think sometimes the
Absolutely.
ultrasound. So, then end up going for CT to make that diagnosis. And actually, yeah, you brought up pregnancy because it's one of the kind of interests I have, which is acute abdominal pain in pregnancy and using MRI for that. So we do use ultrasound and then MRI in that particular scenario. And in fact, just I think I'm allowed to make a little plug on behalf of Radiopedia, which is you should all go check out my lecture on MRI and acute abdominal pain in pregnancy. It's within the Radiopedia lecture collections. But I assume you would do the same in those situations, Carla, ultrasound and then MRI is your second line test.
Yeah, yeah. Firstly, yeah, I'll definitely advise people to go and watch your lecture. I've done that because those MRIs can be one scary, and there are definitely tips and tricks and specifics to those. So definitely, and yeah, we do exactly the same. We'll do ultrasound first, and if it's indeterminate, then we'll proceed to MRI.
Yeah. And what about using MRI in non-pregnant but young patients? Because I know that there are some centers where they're trying to move away from using CT in those situations, for radiation considerations, and using the MRI protocol that you would, or a similar one to the ones you use in pregnant patients, but in non-pregnant patients. Any experience with that?
Yeah, that's a very interesting question. I think our surgeons kind of work differently. So, in male young patients, if they are sure or kind of very sure it's appendicitis, they'll just operate. So, it's usually more the females. Usually, we'll perform ultrasound kind of as a first line always. And whenever kind of there's a young person, usually below 30, whenever there's a CT request, that will be queried and we'll see,
Mm.
have they have an ultrasound and we'll consider MRI. But to be honest, I think if we get requests, we don't get that many, it will be usually females. All the surgeons I ask, they'll say they'll just take a male patient to theatre if they have a clinical diagnosis of appendicitis. So
Yeah.
it varies.
Yeah, it does sound like it varies. You've already mentioned pretest probability, and you talked about it in your lecture, explained it really nicely. So, how do you gauge the pretest probability on your referrals? Is it something you can gauge? Is it possible? And how do you convince your clinicians to request only in those patients who've got a higher pretest probability?
Excellent questions. And I think we as a radiology community need to reach out to the clinicians. We can't just expect them to read our minds and know what we want. I do quite a lot of local lectures. So I literally have that Fagan monogram I have in the lecture in pretty much all my lectures. I also have kind of an open door policy, and without kind of sounding obsessive, I also have the Fagan monogram printed, and on my kind of office door. So when people come to discuss a scan, I will discuss it, and regular staff already know it, probably will roll their eyes, but it's definitely there. One thing I always do, particularly with people, if I because sometimes if people don't know you, they might be a bit taken aback but by me banging on about the Fagan monogram. But there's a website, it's called testingwisely.com. I love it, and I always send it to people because it kind of has educational videos and tests. So I think people can go in their own time and read it. So I think kind of that communication with clinicians is very important. And I think we need to engage because we can't expect them to, read my mind and understand why I'm being very grumpy in the office. So that's number one. After kind of these lectures, people ask, how do I get the numbers for the pretest probability, which is kind of a good question. But my answer is no one needs to get their calculators out. There's not about the numbers, it's more about the concepts. And I'm not saying that we should not be scanning. I think we should be scanning wisely. And I don't know kind of how you feel, but sometimes in a high pressure departments, I think the clinical examination and history is quite cursory, and off they go to CT. And I think it's those patients that I think we need to kind of think, because you think people usually treat our exam results, our scan results as gospel, but even with high sensitivity and specificity, that does not matter. What matters is your pretest probability. And I think our surgeons kind of see that quite well. That's why usually kind of the conversations are quite all right. So my point is not, don't worry too much about the numbers, is the concept. Make sure kind of there's a proper clinical examination, other blood tests and so on. What I don't want to see is, patient coming in for a CTPA if they're having an MI. Someone needs to take a history examination and do an ECG and so on. So that's number one. But if that's kind of well established, then, I'm also against being obstructive for no reason. I think we just need to engage kind of with the clinicians. They have a very difficult job. So it needs to be kind of a constructive discussions. We are here to help the patients, really.
This concept of pre-test probability and then our imaging test and the post-test probability, if I've got the terminology correct, but that I'm not sure it is really widely well taught in radiology training, and it is fascinating if you dive into it. And you know what, I think we should have a Radiopedia lecture about this.
I'll be up for it.
Open invitation right now for you.
Accept it. It's my dream.
Because give us an analogy of, for those who haven't come across this, like how to start thinking about this. Obviously, you've got what you've given in your lecture, but any other kind of ideas?
Yeah, so if you think about it, we all actually work under that process. We just don't have it kind of formally kind of clean our minds. For example, you won't do a pregnancy test in men, would you? Because some of them would be positive because they are not 100% sensitive and specific, but we won't do them because, the pretest probability is none. We know that. We use that kind of clinically. I think it's just where things are less clear. Sometimes there's some confusion, but exactly the same principle applies. And I think sometimes testing without asking what's the clinical question and how will this change management will tie ourselves into knots. So we do know the concept, and I completely agree. It's just not taught at medical school, even though it's the basis of medicine. You take a history, you do an examination, and then you do the tests. And I think sometimes I'm trying to do some posters actually to plaster around the trust on this, just because for all specialties of medicine, that's the essence of our practice. I feel very strongly about it.
Like, Carla, what I'm picturing you walking around Guys and St Thomas's wearing one of those sandwich boards with a Fagan printed on one side and one of these posters on the other side.
I love the idea. I just need to have the one that I have in my wall bigger, and off I go.
Okay, so we're talking about appendicitis and making the diagnosis. Now, once you have made the diagnosis, there's a growing interest in the non-operative management of appendicitis. I think there used to be, so there always has been, but then maybe during COVID, this kind of interest was accelerated because there was a lot of patients not having surgery at that time. So how does imaging play a role in selecting exactly which patients should have this approach or would benefit from this approach?
Yeah, I think actually imaging is kind of the key in this. So if they do have imaging, because, and that's, I think I mentioned that in the lecture, the things I always make sure to report is the things that are going to change management. That is, tip them to do surgery rather than antibiotics, and those are the complications. So perforation, they'll operate. Abscesses on a phlegmon, basically they are less likely to respond to antibiotics, so they will operate. And I also report on the appendicitis, and just because they have a higher risk of complications, so many surgeons will just favor surgery rather than just antibiotics, because that's probably going to kind of later on cause trouble. So our report is key. And so all the summaries and all the reports should say specifically complications or no perforation, abscess, or collection. I always do that.
Yeah. And it's important to stay consistent, with your terminology within yourself, but also within your reporting group as well, so that the way a report is phrased doesn't vary between you and one of your colleagues, so that, the surgeons can rely on the reports and know this is exactly what you mean, right?
Yes. Yeah.
So on the face of it, while it seems a simple disease, appendicitis seems a simple disease, actually from an imaging and clinical point of view, actually it really isn't. And from everything you've said, and we have to remember that perforated and complicated appendicitis does carry a high morbidity with long hospital stays, prolonged recovery times. But thankfully the mortality is actually less than before, right? So it still does make people sick, but mortality is less than before. But in fact, Carla, did you know someone famous who died from complications of appendicitis is Harry Houdini?
Oh,
Yeah, so I've got this noted down here. It's almost 100 years ago, 98-ish years ago, but it's quite interesting. So in October 1926, Harry Houdini, the famous magician, he was in Montreal, and there was a student who asked if he could. Harry Houdini had this thing where he said, "Look, anyone can punch me, and it's fine."
okay.
So the student said, "Okay, well, can I do that to you?" So Harry Houdini, before he had a chance to prepare himself, the student delivered several blows to his abdomen.
Right.
Then he developed pain and fever. 2 days later, he did a show in Detroit, but immediately after that show, he got admitted to hospital. They diagnosed a ruptured appendicitis. I think he had surgery. He had peritonitis. He died 7 days after that. So that was October 1926. Now, it's not clear if the punches actually had any relationship to the appendicitis. It doesn't seem likely, but that's how the story's been told anyway. So
right.
you can die from acute appendicitis. It's quite serious.
Absolutely. That sounds extremely dramatic. We definitely do see very sick patients, and I completely agree. It's not just a simple disease. Our role as radiologists, we need to make sure these patients are treated appropriately. So, our reports, in even appropriate scanning is key. I don't know about the punches. I think probably we shouldn't punch anyone with appendicitis. Or don't punch anyone, probably.
Just punch no one. Don't punch
no
anyone.
One, yeah. And, the number of CT facial bones would be terrible. Yeah, just don't.
Yeah. Now, I want to test out your radiology trivia skills now, Carla.
Oh, God.
And everyone who's at home as well. So there are a couple of famous or eponymous named things to do with the appendix, okay? So if you find acute appendicitis inside an inguinal hernia, do you know what that's called?
I do. Amiens. I have a few examples on my teaching collection. Yeah.
Okay. And do you know who it's named after?
Amiens.
Yes, 100%.
I think. Oh, good.
So Claudius Amiens, 1681 to 1740, was a French surgeon. He actually performed the very first successful appendicectomy in 1735 on an 11-year-old boy who presented with perforated appendix in an inguinal hernia sac. So that's what's noted in history. And then the other one is when you have the appendix and ephemeral canal. Do you know who that's named after?
I can never pronounce it. Garangeau. I'm trying my best French. Is that
right? Yeah. Yeah. René Jacques Croissant de Garangeau.
Croissant, love it.
Yeah. So his life overlapped with Amiens. So 1688 to 1759. Another French surgeon, Parisian, and he described this in 1731. So those two 17th, 18th century French surgeons, we have to thank for those two wonderfully named, eponymously named conditions.
Yeah, I do love them when I see them. And I always save them to my teaching collection just to show off.
Okay, so I want to talk to you about appendix masses now, and specifically the terminology, because you mentioned you talk about how we shouldn't really be using the word mucocele.
Yeah.
For most cases, when we say mucocele, it's actually likely to be an appendiceal mucinous neoplasm.
Yeah.
But I find that the terminology lags behind a bit, or the adoption lags behind the publication. So
Mhm.
I'll say this is a likely appendiceal mucinous neoplasm, and they'll say, "Wait, what do you mean, Vikas? Isn't that a mucocele? Is that what you mean?" Do you find that?
I did, but actually, just yesterday at my colorectal MDT, we had two cases of likely appendiceal neoplasms referred as mucoceles, and I had already mentioned this at kind of a previous colorectal MDT. So when I lift my finger to correct, they already knew that. There's definitely a lot of confusion. Even that paper that I showed is not that old, and even in terms of kind of pathology, now they are kind of lambs and hams are classed malignant. So there's definitely a lot of confusion. But I think in summary, anything that looks like a mucocele, it's likely appendiceal neoplasm, mucinous neoplasm, rather than a true mucocele, which are actually, from the literature, really not that common. So you'll most likely be right by saying that. And I think people appreciate if you kind of just clarify things that are confusing. One thing I really try to engage is in teaching, and I think Radiopedia does a great job because of that. I think teaching is saving lives in slow motion, really, and it's just a great way to improve patient care. So thumbs up for Radiopedia for putting all of this, together. Our surgeons do have kind of weekly teaching very early in the morning, which is not my thing, but I've plugged myself into several of their teaching sessions, looking very disheveled. And they do appreciate it, and I think they keep asking for more. So I think maybe we should be more open to interacting with other specialties. I think it helps us too, and I think it definitely helps the patients. I'm preaching to the choir with you, but
No, but I love that. You really talk positively about that importance of collaboration between us as radiologists
for
and
sure.
surgeons, not just with appendix, but with all sorts of different diseases. So you mentioned before you have your open door policy, you get to know each other, you talk to them. Any other tips for us how to foster that positive relationship?
I think we need to reach out. I really do. I don't think we can just expect for things to happen. And I think generally medicine, sometimes there's a bit of a combative environment between the different specialties. And I think for me, kind of who did kind of another degree came from a different environment. To me, that's quite obvious, coming almost from kind of an outside look. And I think it just becomes a bit of a culture. And I think kind of you see that kind of in multiple places. And I really think kind of we should work hard against it. And, you'll get what you give. So, we do have to make an effort to be open, to be respectful, to listen, and to be able to change our minds as well. And I think people will see that and kind of give that back. I also have quite a lot of biscuits and treats in my office,
Yeah.
and I do give them away after a big, argument about the Fagan monogram. Here's a biscuit, and it does work. And I think sometimes people just come into my office to kind of grab the biscuit or hide from clinical work. Biscuits do go a long way, and it's an honest opinion. Even the cheap ones, yeah,
Oh, if I worked in your department, Carla, I'd be there
yeah.
on a daily basis just to get
It's
biscuits.
a pantry. I even have fruit.
Oh, fantastic. Choice for everyone. Healthy,
Exactly.
healthy choices. So going back to appendix and mucoceles and not mucoceles. So you mentioned there's this entity called a true retention cyst, which is
Yeah,
kind of what what is strictly speaking a real mucocele, right?
exactly. Yeah.
And then there's the ones we should worry about, which are lambs and the distension related to lambs. Is there any way to differentiate those true retention cysts from lambs?
No. So there's
Okay.
no way to tell on imaging. One of the papers kind of I quote, it was from a tertiary center for sure, so things might be a bit biased, but they looked at 188 patients reported as mucocele, and only one out of 188 was actually a true
Right.
benign mucinous retention cyst. So what we've called mucocele and we presumed were just benign retention cysts are most likely lambs or hams, which we can't distinguish on imaging as well. So I think mucocele is probably a bit of a myth. It doesn't seem like a true retention cyst, which is presumed the result of fibrosis, appendicitis, and so on, are actually not that common. So if you just say lamb or ham or likely appendiceal mucinous neoplasm, you'll be most likely correct
Yeah.
statistically.
the kind of, I guess, end stage, if you like, of that whole process is pseudomyxoma peritoni.
Mhm.
So, when it's ruptured and then there's mucinous spread throughout. For those studies, do you routinely use oral contrast?
Yeah, we will. We don't kind of at Kaizen St. Thomas, we don't treat them in terms of cryoreductive therapy, but we'll basically kind of follow them up in the ones that, for example, either kind of had curative surgery and then are just on follow up. Definitely oral contrast. I
Hmm.
find them really difficult. And I think the oral contrast really decides the small bowel loops and separates small bowel loops from small mucinous deposits that, might be confused with kind of a fluid filled small bowel loop. So definitely really helps.
I don't know what you think, but I think one of the areas I find most challenging is picking up the earliest signs of that developing mucinous disease. And I think what
Yes.
happens is once it's very obvious, I tend to go back and I look, could I have spotted it 1, 2, 3 scans earlier?
Yeah.
And it's really difficult because the signs are subtle and they're there in hindsight, but whether you would pick them up when it's in front of you without that prior knowledge, they're very difficult.
Very difficult. So sometimes kind of I will pick them up, but it's when they are massive. It's kind of an easy job. And you kind of, you see them kind of growing over time. I think obviously with a retroscope is much easier, but I'm pretty sure I missed some that will come up in a few years. And I think I have two tips. The first one is the post-op histology, but that's the same with any thing I report for malignancy. So if you have a post-op histology of a mucinous neoplasm of whatever origin, you need to look for them. And if you have that clear in your mind, you need to look for them. I think it makes things easier. And particularly if there was perforation or R1 or R2 resection, it just takes time. The ones kind of I see missed, or I'm sure I'll miss, because we tend to kind of not look at the peritoneum, usually in an acute abdomen, or I mean, we'll do a bit in kind of colorectal cancer and so on. But I always make sure I have the peripheries, which are to me my blind areas. So the subdiaphragmatic region on coronal, always around the liver and spleen, those paracolic catas. And I think because kind of again in colorectal, we will look at the paracolic catas, but sometimes that pelvic peritoneal reflections around the mesorectal space, retrovesical, the iliac fossa, they do go there because kind of if it's the appendix, it's kind of just kind of easier spread. So you just need to know they could be there and just be careful with the peritoneal reflections.
A lot of radiology is understanding pathophysiology and anatomy, and
Yes,
then the radiology is fairly predictable. So if you
exactly.
understand, patterns of peritoneal fluid flow in the
Absolutely.
abdomen, where the most dependent sites are, those are where you're going to find those disease foci. So, and then building that into your mental checklist, or maybe even an actual checklist if you use a template for reporting,
Yeah,
that will remind you to look
for
in those
sure.
places.
There,
Yeah.
there are definitely good templates out there that come up in the last few years, and it will just force you to look at those spaces for sure. I don't have one, but now maybe I should come up with
Yeah.
one.
Oh, brilliant. Thank you so much for all this interesting insight into disease of the appendix. And it's been really fascinating. But I'll tell you what, I'm still finding very fascinating your astrophysics degree. I just can't let it go. So I want to ask you, if there was a way you could combine your two interests, right? Astrophysics and radiology, then would you? So, like, would you go into space and be a radiologist?
I would love to go into space. I checked, but it's very, very expensive. And I think I would love to report at zero gravity. I could strap myself to the workstation. But okay, I'll tell you something interesting. We probably know about the concept of background radiation. So we'll have kind of background radiation from rocks and so on. And a portion of it is from cosmic background radiation, which is actually a shock wave, basically. It's kind of a product of the Big Bang. So it's kind of formed at the origin of the universe. So we are at this moment being kind of
Wow.
crossed by particles, yeah, from the origin of the universe, which is quite something.
Yeah.
And the thing is, kind of when we are on Earth, you have kind of the atmosphere, so that kind of radiation is low. But people in space will definitely have about, say in the International Space Station, they'll have about 50 more radiation exposure if they are kind of in space. So I
Yeah.
think for those that have dosimeters, dosimeters, just don't take them to space. It
Yeah.
will upset your boss if your radiation dose comes back through
Yeah.
the roof.
Leave it at home. Yeah.
Leave
Yeah.
that at home and then go for it. Yeah.
Now, look, this link between space and radiology it's not an entirely tenuous link, because I did mention a couple of space-related items in my lectures on rectal cancer. So I'm just going to list a few. So first of all, COMET. So COMET's the name of the trial that's investigating how good MRI is at differentiating tumor deposits from nodes, because we know that tumor deposits are really important. Their prognostic importance is being appreciated. But also, comet, the tail of a comet is the appearance you get of a tumor deposit emerging from a vein that's got tumor in it. So that's EMVI. Mercury. Mercury is the name of a study group which is founded by Professor Gina Brown from London, from the Royal Marsden Hospital, now Imperial College. It's done a lot of work in the development of understanding of rectal cancer MRI features. And then Star Trek. So there's a
Oh.
trial looking at the therapy options for low risk rectal cancers, and that's described as that goes by the name of Star Trek. So yeah.
I love it. Can I ask you a question, just kind of
Yeah.
talking about kind of the rectal cancers? Because obviously kind of with appendicitis, usually we have quite a quick feedback on kind of our reports. We'll have post-op notes and histology. And obviously kind of with rectal cancer, because fewer and fewer patients are being operated on, how do you think we can maintain our accuracy in our reports?
Yeah, it's tricky because the only like for like comparison you get of our staging, radiology staging versus histopathologies, for those very low risk tumors that go straight to surgery, right? But for
Yeah.
all the others that have chemoradiotherapy or TNT,
Mhm.
we may well have overstaged them and
Yeah.
never know.
Yeah.
And so a marker for quality in those is now shifting to defining whether there's an incomplete response or complete response. Okay, so if there is an incomplete response, then the patient should go for surgery, and then we'll know from the pathology whether we
Yeah.
were correct and there's
Mhm.
tumor there, and things like whether there was EMVI or not. If it was a complete response, then the patient should be having concurrent endoscopy while they're on the watch and wait pathway.
Mhm.
And then we'll know whether what we're calling a scar is
Yeah.
really a scar endoscopically. Of
Yeah.
course, some patients who we call as a complete response will choose to have surgery.
Mhm.
And so in those, we'll get to know whether or not it really was a complete response or not. But my main message to everyone is actually, just like in the rest of radiology, just like appendicitis, always track your outcomes and
Absolutely.
pathology results, because that's the only way you're going to know whether you're how accurate your reporting is. Otherwise, it won't be given to you. So you've got to really try to make an effort there.
Yeah, I completely agree. Even kind of post-op notes in acute abdomen and so on, it will just, sometimes will leave you chuffed, sometimes will make you humble, and you'll
Yeah.
go back and review and learn. Yeah,
Yeah.
100%.
Okay, so look, we're almost done here, but I just want to go back one last time. Promise you, one last time.
Okay. It's really not that exciting.
I keep breaking my promises. Okay, we're going to go back one more time
Okay.
to the whole space theme
Yes.
and ask you, which is your favorite space themed sign in radiology?
I think I'll go probably. Okay, we are GI HPV radiologists, so I'll go for the starry sky appearance of the multiple biliary hamartomas on the MRI, because it's such a perfect description and
Yeah.
they look really cute. So
Yeah.
that'll be my top one. And what about you? Do you have any? Don't say comets, because that's was that what you're going to say?
I was going to say the comet sign. Yeah.
Oh, see, no.
I'll be a true Radiopedia ambassador and saying, actually, there is a whole article which lists loads of astronomical inspired signs. You can go and just search for that, and you'll find lots of different ones listed there.
All right. Sounds good. Good answer. Good answer. I'll have a look as well.
Yeah, you have a look as well. Look, by the way, I was actually going to just wave goodbye to you like this, right?
Mm-hmm.
Then I thought, no, it's a bit boring. So then I thought, well, hang on, just talk about Star Trek. So I was going to try to do the Vulcan salute. Okay,
Yeah.
so people who know about Star Trek will know Vulcan salute is when you put your index and middle fingers together and your ring and little fingers together, and there's a gap between them.
Yeah.
And then you put your palm up, and then that's the Star Trek salute, right?
Yeah.
Now I can't do it. I literally can't do it. I have to force my fingers. I can't.
Like this.
Can you do it?
Yeah, with both hands.
That's amazing. I just can't do it.
I don't find that possible. But at least you can say live long and prosper.
Live
least.
long, live long and prosper.
And that's just about right. All right.
Okay, so now everyone at home is going to be trying to do the Vulcan salute. This is great.
Not
Okay.
that difficult, but all right.
It's been lovely chatting with you. Thank you once again for joining me for this chat.
Thank you very much for having me again.
So smooth. So smooth. There you go. Thank you to Vikas, Shah, and to the wonderfully chatty Carla Goncalves for recording that discussion there. He's actually stolen my shtick there, Gaylard. He worked in some trivia, some pop culture references. He's gone too far. Vikas needs to be stopped.
He's very good. We love our Vikas.
So there's plenty to talk about from that discussion there, Gaylard. First up, though, there are a few reasons why I selected this panel for this episode today, and they relate to our virtual conference, Radiopedia 2025, which is coming up in July. So those of you who've seen the graphic design for the conference will probably be aware that we have a bit of a space adventure theme going through the event, including a session on day 5, which is titled Beyond Earth. So in this session, we have lectures on imaging for spaceflight operations by Wee K. Chong, radiation protection during space missions by Tim Squire, and a lecture entitled From Stars to Scans, Communicating Science Effectively by Pedro Russo. And this one was one that was recommended by Carla herself. And I suspect there'll also be a panel discussion in that session, no doubt featuring Craig Hacking, because he is a massive space nerd and will struggle to keep him away from it.
Space nerds unite, Dixon. I won't have you besmirching space nerds. Craig and I actually visited one of the space shuttles together years and years ago, and it was fantastic. It was so much bigger than I ever imagined. It was heavy and metallic and had rivets and looked like a tractor rather than a shiny Star Trek sort of thing. And I'm actually thinking that in some point in the future, hopefully when they stop blowing up, I'd like to go to Texas and watch a Starship launch. But I think I'm going to wait maybe, I don't know, just a random number, 4 more years maybe before I go.
Very good, very good. And speaking of day 5 at the conference, there's also a session entitled Errors and Uncertainty, hosted by Joe Molyneux, which will include the lecture that Vikas Shah pretty much commissioned during that discussion there. So a lecture entitled Pretest Probability, Maximizing Value, Minimizing Risk by Carla Goncalves. And also in that session, we have lectures by Francis Deng on learnings from malpractice cases, and a lecture by some old dude who sits up and looks down on everyone named Frank Gaylard on how to get better by being wrong.
Yes, one of those lectures that results in people looking at me even more weirdly. No less weirdly than someone pulling a Fagan nomogram out of their shirt pocket, I expect, though.
Yeah, exactly. Or wearing it as a sandwich advertisement or whatever it is. I did say I would explain a bit more detail about the Fagan nomogram. So, yeah, as you said, nomograms are where you draw kind of 3 vertical lines with dots on them, and then you draw a line between 2 of them, and where it intersects the other, it gives you some useful answer without you having to do the calculations yourself. So in this case, it avoids you having to do complex Bayesian mathematics and statistics. So you have one line, which is your pretest probability of a disease. You've got 99.9% at the top and 0.1% at the bottom. And that's kind of, based on your clinical assessment, blood tests. What do you think the chances of this patient having the disease is? Then you have a positive likelihood ratio in the middle line, and that's calculated using the sensitivity and specificity for the test. It's sensitivity divided by 1 minus the specificity. And then you draw a line between your pretest probability and your positive likelihood ratio, and where it intersects the third line, which is your post-test probability, you get what your post-test probability is going to be. So this is just a quick way, really, of proving to someone whether a test in the given situation is likely to help very much or not. I think it's something, to have a play around with to help you kind of communicate the concept rather than specifically using it every day.
Maybe they should be printed on all our request forms.
Yeah,
You're not allowed to ask for a test until you draw the line.
Draw the line. And you just say, draw the line. That's it. And they know what that means. Hello. And you just answer the phone. Hello, draw the line. Draw the line. I must say, I really liked Carla's analogy of, you wouldn't order a pregnancy test in a male patient as a nice way
Yes.
of introducing the importance of pre-test probability, because you will get false positives.
Yeah.
You will get men that come back as being pregnant according to the beat HCG test. And
Yeah.
so therefore you need to take into account that pre-test probability as to whether the test is going to be any use in your clinical situation.
Speaking of things Carla said, I loved her line about education is like saving lives in slow motion.
Yeah. Yeah.
I'd never heard that before, and I think it's perfect. It really captures the value of teaching, both teaching in person at the hospital and online, and what it's all about. You don't see the effects immediately. I mean, you see the effect that you're not reporting more scans because you're giving a tute instead, but you don't
Right.
see the effects of that teaching immediately. But they're there, and sometimes they do literally end up saving lives years or months down the track, maybe even generations down the track, because the thing
Yeah.
that you teach can change someone's way of looking at the world. And I think it's really powerful to remember how much of an investment in the future teaching each other is.
Yeah, that line from her stood out to me as well. It's slow motion, but the effect is amplified over time, is the thing, isn't it? So I'm not sure there's an analogy that works, but maybe like a river that carves the canyon or something
Yeah.
like that. It's something that seems kind of innocuous at the time. It seemed like it was getting in the way of your day and stopping you from reporting cases, but in the
Yes.
end, it
Yeah.
carves this massive canyon of knowledge in the world, which is worth
Well,
way
and that's
more.
right. I think the idea that it amplifies over time is really important, and that's certainly as a tangent here. But that feeling is what has led me, and I think you as well, focusing more and more our attention on radiopedia rather than on our clinical work, because I genuinely think that the amount of positive impact we can have on patients' lives is
Mm,
greater through the work that we're doing with Radiopedia, which teaches thousands of people, than sitting in a small dark room reporting meningioma follow-ups. So yeah, absolutely. I think it's incredibly important, and I love to see people incorporate teaching into their everyday
mm,
sort of habits. There was one more thing though that I wanted to bring up, which was I thought it was interesting to hear that even between just Carla and Vikas, there were differences in the approach to the diagnosis and management of appendicitis.
mm.
And at Carla's hospital, they would operate based on clinical findings, whereas even at Vikas, they required imaging. And I'm, I'm a bit torn here about this particular issue, not specific about appendicitis, but generally. The grumpy old man side of me wants to complain about how the art of physical exam has been lost and how we don't get enough clinical details on requests and how young surgeons and physicians, only know how to order a CT scan, etc., blah, blah, blah. But the rest of me, which is actually, I think, the louder, bigger part, thinks, well, CTs are awesome.
Yeah.
And I certainly wouldn't want my belly opened up or my kid's belly opened up without some imaging, preferably
Mm,
ultrasound, if it's good and available. But whatever, doses are so much lower than they were. And the choice of how to navigate the pathway between someone turning up with lower quadrant pain all the way to fixing the problem, whether it be surgery or antibiotics or discharge or whatever, is so highly dependent on the local constraints and resources that you have. Not just, the radiation dose of CT, but even then, like, what's your scanner like? How new is it? What is the radiation dose? And
mm,
how young the patient is, etc. But there's the surgical risk, there's access to scanning, there's access to surgical theatre, and what happens with that surgical slot for occasional unnecessary appendicectomies. What else could that slot have been used for? What's the skill of the surgeon? What's the skill of the radiologist? What's the cost? 100 other factors. But ultimately, I think we are moving towards more imaging, not less, right? And finding ways of reducing the dose and the downsides of imaging and improving access to it, I think is probably more important than fighting what is ultimately going to be a losing battle over clinical examination, because clinical examination just, it's not that good. That's why we
mm.
invented CT, because poking and prodding just, yeah,
Especially when the CT not only can find other additional diagnoses, the differential diagnosis for that condition, but
yeah,
also, as we heard in that discussion, the CT can determine whether you might manage it conservatively rather than with
Yeah.
surgery if there's no perforation collection, no appendicolith in the case of appendicitis. So the fact that it's feeding in directly to the management just makes it even more of a likelihood that that's going to happen. One interesting kind of paradox I think that I've observed is that the imaging modality that is available 24 hours a day will generally be the one that wins out, for example,
Yeah.
CT, over even the preferred modality if it isn't available all the time.
Yeah.
So during the daytime, I still see CTs being requested instead of ultrasound just because it becomes a routine thing that the surgeons and emergency doctors order CT because, sometimes you can't get ultrasound, it's a hassle, blah, blah, blah. So they just default to CT, even though obviously ultrasound in a skinny young male, female, going to be a great test to look for appendicitis. You kind of need that 24-hour a day product, and that's what gets into
I
their
think
heads.
that's certainly part of it. I think the other thing is that, squatch blob problem, which is when a surgeon looks at a CT, they immediately understand what they're looking at and there's certainty about it. Whereas when you look at an ultrasound, the thing that has been labeled appendix, it's on the images that are saved, it's much less easily transferable to when you look at the patient, I think. All things being equal, you would get a CT and an ultrasound, right? Aside from the radiation dose and access, etc. If you could just snap your fingers.
It's similar to sometimes doing like a joint injection or something. You might
Mm,
often use fluoroscopy for it, which has a little bit of radiation because you can get a nice picture of contrast distending up the joint and you
yeah.
can prove to anyone, yep, I was in the joint. Whereas on ultrasound, it's a
Mm,
dynamic thing. You can definitely do procedures, joint injections very, very well with ultrasound, but it's much harder for the surgeon to look at the images and go, yes, he's definitely in the joint there.
yeah.
It's not as easy. So therefore, kind of like, well, I'll just do it under fluoro. So there's no questions about whether my injection was in the right spot or not.
There's one more thing I wanted to bring up, and it's not radiology related, but space related.
Oh,
I don't
excellent.
have a telescope, and I don't really want one. I don't want to be the kind of person that runs around with a telescope. But I do remember very vividly when we were on our honeymoon, we were on some island somewhere, it was the Maldives, and the resort had a telescope on the beach. And I remember looking through and seeing Saturn with its rings. And it was a terrible picture compared to what you get in a book or online. There was no color, you couldn't see the rings, it was just like white, just the shape, really. But there was something really important about knowing that the photons that were hitting my retina and forming that image had actually gone from the sun, bounced off Saturn, and then come back to Earth through the telescope and into my eye. And I don't think it makes a lot of sense, maybe, but that experience really struck with me. And so when
Yeah.
Carla brought that up, it was like, yep, that's definitely a thing. So if you haven't actually looked at a planet with a telescope, a real telescope, not connected to your phone or anything, I encourage you to do it if you're nerdy at all, because it had a profound sort of I am so
Yeah.
tiny effect.
Yeah. And especially if you have kids as well, I think it's a great thing to show your
Yeah.
kids. We've done it. We have got a telescope at our house, but I tell you what, the amount of light pollution though we have in Melbourne doesn't make it very easy
No, you have to
to
go
look
to
at
the
planets and
country.
things. Yeah.
Yeah.
I think it might be time to wrap this episode up,
Yep.
Gaylard. How can people get in contact with us?
Well, they can email us at podcast@radiopedia.org with any ideas and or feedback, like requests for more meat-related updates. Just hinting here. And you can join the Radiopedia community chat by visiting radiopedia.org/community.
Yeah, so you can send an email just like Talita in South Africa, who writes, Dear Doctors Gaylard and Dixon, see
Mhm.
what I did there? That's what she wrote. So she's deliberately put you first there, Gaylard, knowing that clearly Andrew's more important. I have a proposal for April Fools. We often joke about therapeutic x rays when a patient who was previously in an extraordinary amount of pain can suddenly mobilize the limb in question and even weight bear after learning from the x ray there is indeed no
Yes.
fracture. It would be a hoot if you wrote an article about the effect of x rays as a pain management tool in the emergency department, something about ultra low diagnostic radiation doses as an adjunct for acute pain management. Stay rad,
Oh,
Talita.
that's a great idea, but my worry is a little bit like the pyramids that people would actually believe it.
Absolutely.
When
Yeah.
I was a trainee, having just finished a night shift, it must have been 6:30 or 7 in the morning. I overheard one of the radiographers in the emergency room getting a phone call from the ward asking them to do a mobile x-ray. And they said, "Oh, I'd love to come up. Unfortunately, the delivery of photons has been delayed and we've run out. So it won't be able to happen until after 8:30.
Very good. I think you've told that one before on the podcast, but I'm going to let it through on this occasion because
sorry.
you are
Old man.
an old man. And if you want to help support Radiopedia, then you can become a paid supporter via the website or purchase an all-access pass to our online courses and conference. In doing so, you'll be helping us to give free course and conference access to people in 125 low and middle-income countries. We will be the river that carves out the
Yes.
canyon with our education. And what else can people do to help us out, Frank?
And you can also help by leaving us a 5-star review in the podcast app of your choosing.
Excellent.
We should get Vikas to record that line so that he can say
yeah.
it in smooth Vikas tones.
Every week, you reckon?
Yeah.
Slightly, has to do it slightly differently every week.
We could just get him to sit down and record 50 in a row, and we'll just use one each.
I'd be so tempted just to play all 50 in a row as a whole episode. All right, and we'll catch you all again sometime soon in the reading room.
Stay rad, everyone. Stay rad.
Stay rad. See you later.
Bye-bye.
Look at the stars, everyone. Look at the stars.